Lenny, you've had a lot of experience now with the BAHA. I know that you modified the technique as originally described. Tell us about your experience.
Thank you, Bill. The BAHA, which is the bone-anchored hearing aid, or now also known as the B.A.H.A, the bone-anchored hearing device, I think is a great addition to what we can offer patients for severe hearing loss, central neural, conductive, or mixed. I would like to discuss some technical issues which I have found very helpful. We do all our BAHA surgery under local anesthesia with sedation, unless it's a child under age 12. These are outpatient surgeries. The standard marking is done of the template where the titanium implant will be placed. The infiltration should be adequate, and the patients will not have any sensation of pain during the surgery, and the hemostasis by using 1 to 100,000 epinephrine is very important. The standard...
Hold it. 1 to 1,000 or 1 to 100,000?
1 to 100,000.
Okay.
Yeah.
Right. So repeat that.
Yeah. We use 1% lidocaine with 1 to 100,000 epinephrine. The dermatome, which comes from the kit from the Coker Corporation, is excellent. An inferior-based skin graft is established, and a large rectangular block of tissue is taken down to the periosteum. The periosteum is then exposed, and using 3 and 4 millimeter drills under constant irrigation, the site in the bone is prepared. This is generally 50 to 55 millimeters posterior superior to the external auditory canal. Of course, you have to keep in mind that some patients will wear a hat and some patients will wear glasses, and you have to properly position with some adjustments a couple millimeters posterior or inferior due to these issues. In addition, some patients have had atresia surgery or acoustic neuroma surgery. They might place the implant a little bit more posterior. Then we go on to the countersink, which is a 4 millimeter, and prepare the well for the titanium implant. Wide undermining, which is critical in order to create a nice shallow and gradual contour for the implant. We then will create a dermal periosteal closure, which is critical to avoid dead space and eliminate the chance for a hematoma. I will, in addition, depilate the skin graft with a number 10 blade in order to decrease the chance for cyst formation. Once the implant is placed, we will then suture the skin graft superiorly using a skin punch to expose the titanium implant. What I will do then is a minor modification. I'd like to show this on a diagram. You can see the skin graft here with a titanium implant. And what I do is take a little bolster dressing with cotton and Zeroform and 2O nylon, and I will suture it below the site in order to prevent fluid accumulation underneath that skin graft. And the first 5 or 6 that I did of these, I was an issue. And since I've done this in the last 90 or 95, I haven't had any issues of skin graft loss. I highly recommend that. Now we will remove the pressure dressing 1 week to 10 days after the surgery, and then within 2 months we will place our processors. Our patients have standard antibiotic coverage. We do recommend that they use antibiotic ointment over the surgical site, and this seems to do very well.
Lenny, when you started to do the BAHAs, we looked for patients who had excellent hearing in one ear and no hearing in the other. And then we went to the patient who had a little bit of hearing loss in the good ear down to 20 decibels or 25. We started to feel squeezed at that time. And where the bad ear was only down, let's say 80 or 70, but with terrible discrimination. Now I know that you have changed your criteria since then, because you wrote a paper now describing the patients that still do well without having such good hearing in the good ear and such terrible hearing in the bad ear. Tell me about that.
I think the standards for how good does the good ear here are fairly well accepted, and we've discovered this as well as after testing hundreds of patients with the test band and audiometrics. You really can't fit a BAHA on a patient whose good ear is less than 30 decibels when we're talking about single-sided deafness. Of course, the atresia patients or the chronic ear patients have been well defined over the last 20 to 30 years. What's really interesting is the use in single-sided deafness, and how bad does the bad ear have to be? And we have about 6 to 7 patients who are not deaf in the ear, particularly Meniere's patients, that once their hearing loss has been established, they have discriminations in the range of 40 to 50%. They can't be helped by a conventional hearing aid. We've put the test band on them. We've implanted these patients, and these patients are quite satisfied. So we did publish this, and we continue to operate on patients who don't have complete deafness in the poor ear, and they're satisfied, and we're satisfied with it.